Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the top 200 drugs. It's a great little study guide, great refresher. You can do that at reallifepharmacology.com. Simply an email will get you access to that free 31-page PDF on the top 200 drugs. So again, head on over to reallifepharmacology.com and find that free PDF. All right, so we are going to cover some of the most commonly tested skeletal muscle relaxant type medications. So first off, I want to cover baclofen. This is definitely a medication I see used in practice quite a bit. It's got some GABA B receptor agonist action, which inhibits excitatory neurotransmitter release, primarily focused in the spinal cord area. And this can ultimately help reduce muscle spasms or spasticity from things like multiple sclerosis or potentially like spinal cord injury and other diagnoses like that. From a dosing standpoint, usually I see this medication used 2 to 3 times a day, mostly probably 3 times a day. Again, when we're managing, pain, discomfort, spasms, it's usually going to be used symptomatically. So if a patient gets by with twice a day, we may use twice a day. From a kinetic standpoint, usually, we may have to do 3 times a day with this medication. Usual starting dose orally, 5 milligrams 3 times a day. We can increase by 5 milligrams every, 3 to 7 days, kind of depending upon how that pain management is going. Also, remember there is an intrathecal dosage form, so that I don't see near as much as utilizing the oral medication, but in more severe cases, you may see that. Important to note with dosing, when we're coming off of this medication, and I would say in general, probably for most of the skeletal muscle relaxants, it's a good idea to taper off slowly, particularly if they've been on it for a long time. So, again, I want to kind of avoid any type of withdrawal symptoms if we can, and obviously help that patient be a little bit more comfortable there. All right, adverse effect profile with baclofen, and this will probably, a lot of these will probably be true for most of the skeletal muscle relaxants. They tend to be sedating. They can increase the risk sometimes for dizziness and falls. Also, many of them act on the central nervous system, so confusion, and that's all true with baclofen. Usually, these are all dose dependent. The higher the dose, the more sedation you're going to get. And then going along with the tapering that I mentioned, with withdrawal or abrupt withdrawal of this medication, in rare cases can contribute to seizures and rebound spasticity. So important to pay attention there for sure. Other important practice pearls, clinical nuggets, drug interactions. So having the sedative properties of this medication, what I look out for in practice is additive effects from CNS depressants. And that could be prescribed medication, such as benzodiazepines or opioids, first-generation antihistamines. These are all sedative by nature, but it could be something the patient's doing on their own, whether that be, alcohol intake, for example. So very, very important to recognize that. Could have some CNS depression, sedation type activity. One last thing I'll mention, I see this medication used quite a bit in geriatric patient populations, so I think it's important to really start low and go slow when we're talking about titrating up on this medication. The sedation, the dizziness, the central nervous system effects like confusion, these can all be exacerbated certainly in a patient who is elderly, maybe doesn't break down the drug as quickly, and just is on a bunch of other medications besides. So pay attention, start low, go slow if we have to use this medication in a geriatric patient. Next medication is tizanidine. This is a central alpha 2 adrenergic agonist. This, again, can be utilized for muscle spasms. Dosing is usually 2 to 4 milligrams. I probably most often see 2 milligrams, particularly in my geriatric patient population. And again, dosed pretty frequently every 6 to 8 hours. So that kind of tells you that the half-life isn't incredibly long or anything. Usual range, if we need to titrate, in that 8 to 24 milligrams per day dosage range. Again, because of that short duration, we do have to dose this one pretty frequently. All right, side effect profile. Sedation, dizziness. I also want to specifically mention hypotension, so low blood pressure. Now, if you remember tizanidine, you can think of a little bit of clonidine. These work the same way, and clonidine is a medication that we can use to actually lower blood pressure intentionally. So tizanidine can certainly have some overlapping effects like that. So we should definitely pay attention to blood pressure a little bit with this medication, just understanding that pharmacology. In addition, got to pay attention to dry mouth. This is something I have certainly seen in practice. And going along with the drop in blood pressure when this medication is utilized or given, when we pull that medication away, or if we pull it away too abruptly, we can have rebound hypertension. So a spike in blood pressure if the patient doesn't take this medication for a significant period of time and they've been on it for a while. So that is a really, really important one to remember and recognize as well. If you see a big spike in blood pressure, abrupt removal of tizanidine could potentially cause that, just like clonidine, for example. All right, important drug interactions with this medication. Strong CYP1A2 inhibitors. The one I've seen in practice probably most is ciprofloxacin. This is actually contraindicated. It can raise concentrations significantly, and ultimately that can lead to increase in sedation and excessive drop in blood pressure as well. So really, really important to remember that one. One other one I guess I'd mention is fluvoxamine. This medication is an SSRI. It's rarely used due to having a bunch of drug interactions, but it also is a strong CYP1A2 inhibitor and a good one to remember with tizanidine. Others that, maybe, to a more mild effect, or maybe you see less often, cimetidine does have some CYP1A2 inhibition type activity. So again, maybe pay attention to that one a little bit there. Other drug interactions to think about, antihypertensives. So we can certainly have that additive hypotension effect. So if you have somebody that's borderline low blood pressure and then we add tizanidine on top of that, certainly that could have some additive effect. And then just like baclofen, we can have the additive CNS depressant type action, whether that be opioids or alcohol or whatever the case may be. All right, before we move on to the next medication, be sure to go support the sponsor, meded101.com/store. We've got tons of resources there. Pharmacist board certification, BCPS, ambulatory care, geriatrics, NAPLEX exam. We've also got tons of books on Amazon, anything from the MPJE, nursing pharmacology, pharmacology crossword puzzle books, case study books, tons of different resources there as well. All those links you can find at meded101.com/store. We've helped thousands of pharmacists and other healthcare professionals prepare for and pass board exams. and we can absolutely help you as well. So again, go check out all those links, meded101.com/store. All right, moving on, I'm going to cover 2 more skeletal muscle relaxants, or at least medications with skeletal muscle relaxant activity. Next one is cyclobenzaprine. Brand name is Flexeril here. This is a centrally acting agent that reduces tonic somatic motor activity. And one important thing to note that can help you remember adverse effects and how this medication works, it is structurally related to tricyclic antidepressants. So it is going to have anticholinergic activity, and I'll get into that and the side effects coming up here. Mainly used short-term, ideally there. Usual dose I see is 5 to 10 milligrams, 2 to 3 times a day. Again, kind of a shorter half-life agent. So it does tend to have to be dosed a little bit more frequently. Now, on the side effect profile side of things, again, we do have some anticholinergic effects. So dry mouth is notorious with cyclobenzaprine. I've seen that quite a bit. In addition, dry eyes, constipation can also maybe contribute to some confusion, more likely in patients with pre-existing dementia, older patients. The sedative nature of the medication as well can increase the risk for falls. So again, lots of potential adverse effects with cyclobenzaprine. It's not a drug that I love to see used in geriatric patients, but I will say I have seen it in practice a fair number of times. So important to remember the anticholinergic type nature with this medication. All right, important drug interactions. Remembering that it's structurally similar to TCAs. Got to pay attention to MAOI inhibitors, or monoamine oxidase inhibitors, I should say. Again, contraindicated within 14 days. Risk of seizure and elevated temperature, things like that with this interaction. Serotonin syndrome can happen as well. Again, elevation in body temp possible there as one of the effects of serotonin syndrome. So again, SSRIs, SNRIs, TCAs, tramadol, these are all meds that can increase serotonin syndrome risk. Other drug interactions to think about, CNS depressant action, again, just like the others. And then, of course, additive anticholinergic action as well. So, thinking about a medication like oxybutynin, a urinary anticholinergic, first generation antihistamines like diphenhydramine, those are all classic examples of medication that could add to the anticholinergic burden. So again, treat this medication like a tricyclic antidepressant from an adverse effect profile. I think that's a good way to remember this one. You can lump that in with that, and hopefully that'll help you remember some of the clinical quirks with that medication. All right, the last one I'm going to cover is diazepam. Brand name is Valium. This is a modulator of GABA receptors, which can cause central muscle relaxation as well as a reduction in anxiety and some sedative type properties as well. Again, this medication, it is a benzodiazepine, and that's, synonymous with the mechanism that I described there. But I have seen it used for skeletal muscle spasms before. So I think that's an important thing to note here. But it's got all the classic things associated with benzodiazepines. It's got, it's a controlled substance, so there's risk for addiction and dependence. Very similar effects to alcohol in a pill. Sedation, ataxia, confusion, all really, really important things there. Respiratory depression can be exacerbated by opioids, which is a drug interaction coming up here as well. And then withdrawal risk as well. So this can increase the risk for seizures if we have abrupt withdrawal of this medication as well. Dosing standpoint, again, usually 2 to 4 times a day, kind of depending upon when those symptoms are and what the patient needs. In the neighborhood of 2 to 5 milligrams is probably what I see most often. Occasionally maybe I see 10 milligrams in younger patients. But again, there we're starting to get up to, where some of those side effects are going to come into play as we escalate that dose. But usually I most often see in the 2 to 5 milligram range with this medication. Again, with the risk of dependence, addiction, use the lowest effective dose for the shortest amount of time if possible. All right, wrapping up drug interactions here. So I alluded to the opioid one already. There is a boxed warning with benzodiazepines like diazepam and opioids. Significant sedation, respiratory depression, coma, death ultimately are possible. So again, pay attention to that one. Other CNS depressants, gabapentin, your pregabalins, other skeletal muscle relaxants, alcohol, again, additive CNS respiratory depression type effects. CYP enzymes are important with diazepam. CYP3A4, CYP2C19 inhibitors may increase diazepam levels to a certain extent. So I think it's important to pay attention to that. And then inducers of those may ultimately reduce the potential effectiveness of this medication. There's plenty more on all these agents individually. If you go to reallifepharmacology.com, hit the podcast tab, and you should see the search button, or simply just a Google search, diazepam, Real Life Pharmacology. You'll go ahead and find that podcast episode available there as well. So again, much more detail on each of these agents individually, but just kind of wanted to wrap up a nice podcast episode here with these 4 agents that are commonly used for skeletal muscle relaxant purposes and muscle spasms. With that said, I'm going to sign off for today. Please do me a huge favor. Give me a rating, review on iTunes or wherever you're listening. Share us, friends, colleagues, classmates, anybody who could benefit from pharmacology education. I greatly appreciate that. If you want to track me down, mededucation101 at gmail.com. And of course, support the sponsor, meded101.com/store. All your purchases there go directly to help support this podcast, and I'm greatly appreciative of that. With that said, take care. I hope you have a great rest of your day.